Hi everyone, welcome back to the show. I just launched this channel just recently, really, just a few days ago, and I've been quite overwhelmed by the response from people, positive response so far anyway, and just suits my purposes really, because that's the idea, is to produce some sort of editorial which gives people maybe a different insight to the problem that their vet has discussed with them. Sometimes just someone else discussing it and describing it a different way helps it to sort of stick in your mind. So thank you for everyone who's written in. Thank you for all the kind comments. One of the suggestions was that we tackle as our next topic epilepsy, and I thought, well, why not? So it's a sort of a bit of a wet and wild night outside, so if you hear thunder and rain, don't be more distracted than I am by it. So epilepsy, what's going on? I think I'll target the talk a little bit sort of about dogs more than cats, just because it is a little bit more common in dogs than in cats, but really the same principles largely apply. So if we start, so what is epilepsy? What do we mean by epilepsy? What is going on with epilepsy? I think that the way I like to do it is draw a comparison between your brain and your computer. So if you imagine the brain is nothing more than just a great big computer, it can happen that sometimes you can get a short circuit in your computer. It can get sort of jammed in a cycle when you're trying to download something. It can get stuck buffering. It can just freeze. It can just crash. So something just goes wrong in the processor in your computer. Well, epilepsy is very much the same. Something just goes wrong in the brain, and there's a short circuit, and something goes wrong, and it can manifest as anything from the full sort of traditional grand mal jerking seizures that we associate with epilepsy. But you can get much milder forms. Some people call them fly gazing or star watching, where your dog sort of looks at something and sort of sees something and zones out and watches it for a few moments, and then slowly sort of zones back in and goes, oh, hello. Where have you been? And no ill effects at all. They sort of just zap in and out of it. And human beings, it's even more complicated. I think someone told me once there's 60 sort of different variations on forms of epilepsy that we might get. But let's go back to the little metaphor there. So think of the brain as the great big computer. So you've got the computer that controls all the functions in your body. So not just the cognitive functions, not just what's going on in your mind, but also what's going on in your body. So if you were working on your computer, for example, and suddenly just bang, the computer went out, which is the equivalent of let's say the screen went black, which is the equivalent of, for example, an epileptic seizure. Where's the problem? What's gone wrong? Think of the problem as being in the computer or external factors outside of the computer. So yes, your computer may have crashed, it may have blown up, you may have messed your coffee on it, or it may just have somehow got stuck in a loop, like I said. So the problem is in the computer. Epilepsy is the same. In that instance, the problem is in the brain. But equally, the problem could be outside of the brain. So something in the rest of your body which affects the brain. And the analog there again is, imagine your computer suddenly goes dead and you turn around and you see someone's walked past and accidentally kicked the power lead out of the wall. So now your computer's not working, but that's not because there's anything wrong with your computer. Your computer's fine, but it can't work because it's not getting electricity because someone's knocked the cable out of the wall. So the brain is the same. So if you have a seizure in the brain, so you have a short circuit or sparks flying in your head, that could be, yes, because of a problem in the brain, but it could be problems outside of the brain. Classically, think about being drunk, for example. That's a problem outside of the brain, which is affecting the brain in a more sort of contextual setting. If you had a heart problem, for example, and you're just not pumping blood around efficiently, and you're just not getting enough blood to your brain. Remember, the blood carries, amongst other things, glucose and oxygen. So suddenly you're depriving your brain of glucose or oxygen or both. So clearly the brain can't work, and it's going to short circuit and it's going to go wrong. So heart problems can cause it, breathing problems can cause it, drugs can cause it, alcohol can cause it, diabetes, for example, could cause it. Or even if you're not diabetic, if something affects your sugar levels and you're just not getting enough sugar to the brain, then bang, the brain's going to have a short circuit, just like the computer, and you're going to see some sort of seizure activity. So the first distinction I would make is it in the brain or is it outside of the brain? And that will completely affect the treatment options that you might take with it. So the next step is to consider when someone reports to me and says, oh, my dog had a funny turn. This is the most common presentation. And I'm always like, what's a funny turn? Try to get a little bit more information. And the first distinction we have to make is, did you fit or did you faint? Or another way of putting it is, did you have a seizure episode or did you have a syncopal episode? And so really the distinction there is the seizure is the short circuit in the brain because of a problem in the brain. Whereas syncope or fainting is you just didn't get enough blood or glucose or oxygen or something else to the brain, and you effectively flaked out. So there can be a bit of overlap in what it looks like when you see your dog having a fitting episode or a fainting episode, because in both instances they'll just fall to the ground. You may get a greater or lesser amount of jerking and involuntary movement. So in very, very crude terms, to try to distinguish, did you just fit or did you just faint? Which one did you do? As a broad rule of thumb, when did it happen is the thing to consider. So if you have this episode and it occurs at rest, so when you're doing absolutely nothing, you've not just recently exerted, you've not just had a meal, you're just sitting around, chilling out, doing nothing, and then suddenly, bang, you have this sort of seizure and you go into the convulsions. So if it happens at rest, most likely it was a seizure. Whereas if it happens on exertion, and any sort of exertion, so running around in the park, playing with someone, just being excited that you've come home, and that you're putting a lot of energy, a lot of exertion in, so the whole body is calling out for, we need more oxygen, we need more glucose, we need more blood supply. If that demand can't be met, then you're going to have a faint. So seizuring happens at rest, and fainting happens on exertion more often than not. Other things also crude is with the fainting you tend to sort of fall to the floor and you may have one or two little boogies, but that's it. Whereas the classic seizure, it's sustained, it just keeps going. There may be vocalization as you go down, so the dog sort of vocalizes in fright, and they may pee and poo themselves. And if that happens, you would think more seizuring. So if it happens at rest, you get a little bit of vocalization, a bit of and then you're down and you big tonic-clonic movements, and you pee and you poo a little bit. Probably you're seizuring rather than syncoping, which is fainting. The next thing to consider is, apart from what were you doing and when did it happen, is were there phases to this happening? And so I'll focus on seizures first, because fainting, of course, just you may be standing for a long time, that kind of thing, or you've been in the sun too long, or you haven't eaten or drunk and you faint. But with seizuring, typically there's three phases. There's what's called the prodrome, and then you get the actual seizure, and then you get what's called a postictal phase. So the prodrome is a phase where you know something is coming. And people with epilepsy will sometimes describe that. They'll go, yeah, I felt something was off, something was coming. So some people can pick that up and be aware of it. And absolutely, dogs will sometimes pick it up, and they will manifest that as the obvious, really. Think of that, because they don't understand all the science. Think of them as a bit like primitive man going, something's wrong, so I'm feeling out of sorts, something's coming, and they become anxious. And they'll often come and seek you out for a bit of comfort and reassurance with that sort of, oh God, oh bloody hell, please help me, I don't know what's going on. So the prodrome is the it's coming phase. And dogs, not only can they often pick it up in themselves, but they can pick it up in human beings. So you can get epilepsy help dogs, so dogs who are able to pick up the prodrome in us as human beings. And these are dogs like guide dogs for the blind and all the other various disability dogs. You can get dogs trained to live with people with epilepsy who will pick up your prodrome, and they'll come up to you by some sort of prearranged gesture and say to you, listen matey, you're about to have a seizure. If you're doing something like chopping onions with the biggest knife you've got in the kitchen, sitting on a stool, put the knife down, get off the stool, sit on the ground, take your meds, whatever it is your doctor wants you to do. But the dog will tell you something's coming. So the prodrome is the something's coming phase. Then the actual seizure phase, like I said, varies from what we call full tonic-clonic movements. And I would always say to people, describe the seizure to me, exactly how did he go down, yes or no? So did we just have the fly gazing or the star watching, or did we actually go down? If he or she went down, did they just sort of sink down onto their chest but remain fairly compos mentis, sort of looking up at you going, oh my word? Then probably they didn't have a seizure. Then it was probably more a fainting spell. The classic is they go down, roll onto one side, so they're lying on their sides, and you get these sort of paddling movements, front and back legs scrabbling around. You may get a degree of grimace on the face. It's very disturbing and very unsettling to see. I've seen it happen countless times, and I still find it extremely upsetting. My own dog used to do it, so I get that it's horrible, and that's valid. Why? Because your instinct is, oh my Lord, I need to help this poor animal. That, they're in distress. I need to help them. I think I heard somewhere you might swallow your tongue, so I need, which is a nonsense, but you think you need to pull the tongue out so they can breathe. Don't try and help them. You cannot help them. They don't know what's going on. They're completely zoned out. And because of that, the brain's short-circuiting. They're not themselves. They're just not in for the duration of the seizure. So they don't know what's going on. The person who's suffering is you and me watching it because it's so distressing. So don't try to help them. Just let them get over it. I had one client of mine, a very good dentist. Her dog was at the top of the stairs. Who did it? A massive, great Bernese mountain dog. And she was concerned he was going to fall down the stairs. So she went to just pull him back just onto the landing to be safe. And he bit clean through her hand. She got tiny little lady hands. And he had massive, great big bloody dog teeth. And he bit right through her hand. And she was okay, but she might not have been. These guys are powerful and they can shear your fingers off. So don't try and help. Don't try and fuss them. They don't know what's going on, and they'll inadvertently bite you. They're not biting you out of malice. They don't know it's you, but their mouth's often chomping and champing away. Don't do anything. Just if you see a human being have a seizure, similar applies. There's nothing you can do. You can't help them get out of it. If they're doing it on the pavement and bashing their head on the ground, yes, take your fleece off, bundle it up and stick it under their head so they don't injure their head on the ground. But apart from that, just wait for them to come out. This thing about you're going to swallow your tongue and suffocate, rubbish. Don't stick your hand in there. You'll come away from it minus a finger or two. So just don't do it. Don't stick anything in there for that matter. Just let them come out of it. And once and how long could it go on for? Blimey, anything from just a few seconds to several minutes. Try and time it, because that's one of the things we're going to ask you when you describe it. So when did it happen? Was there a program? Did they know something was coming? And when they went down, how did they go down? Straight onto the chest? Was it front and back legs? Were they on their side? Were there paddling movements? Was there peeing? Was there pooing? Was there crying out? Were there champing movements? Was there drooling? What was going on? And how long did it last? It feels like an eternity when you're watching your beloved little Pookums sitting there. Mine was Ellie, my border collie. She became epileptic when she was about 3. It's hugely distressing. I absolutely get it. But time it, because it feels much longer than it is. And then when they sort of zoning out of it and they sort of start looking around, you'll see often they'll get to their feet, these guys, and still be out of it. It'll be something like out of a B-grade horror movie. They'll be completely out of it and up and sort of startled and anxious and wanting to run. Still, do not touch them. Do not approach them. Do not try and help them. They don't know what's going on. They're still in la-la land. So do not try to help them. You can call their name and just wait, and they'll sort of be all over like, the monsters are coming. And then suddenly they'll sort of zone back on you and go, hello, mum. And then when they're back, yes, then call them over to you. And if they're compass mentis enough to come to you, then you can give them the reassurance. That's the end of the seizure phase. Now you're into the postictal phase. And that's just the brain sort of unscrambling itself phase. It may happen instantaneously, so they're out of it, and 2 minutes later, they're absolutely fine. Or the postictal may carry on for quite some time. And it varies from just a bit of disorientation, just a little bit out of it, just a little bit soppy, just wanting the reassurance. They won't recall the event, but their brain will feel a bit fuzzy because they've just with the scrambling effect of the short circuit of the seizure in the brain, their brains are blancmange, and we've just got to let that just resettle. People will tell you the same. Sometimes they'll be a bit emotional, a bit weepy, and it's not because they traumatized by the event necessarily per se. I've never had a seizure, so I can't vouch for it, but having seen them, I think it's really just this disorientation phase which is unsettling, and they're quite tired. It's quite exhausting having the seizure. So also time that, sort of how long is the postictal phase, and exactly what characterized the postictal phase. So once we're satisfied that yes, my dog has had a seizure, the next question to consider is where we started at the beginning of the story is, well, where was it? Was it a problem in the brain, or was it a problem in the rest of the body affecting the brain? To try guide us on that a little bit, look at sort of the age and the breed of the dog. Usually if you're going to be epileptic, if you're destined to be epileptic, you're usually going to have had your first episode before you're about 3 or 4 4 years old. It's not carved in stone. It's not a forever rule, but usually you will have demonstrated this. If you're having them very, very young as a dog, like just a few months old, and particularly if they're happening just after a meal, you would think you would guide your thinking maybe about a thing called a portosystemic shunt, which I'm not going to go into too much detail, but it's basically a congenital abnormality where you've got an extra vessel in your body which instead of filtering your blood through your liver to clean it before it gets to your brain, you've got a blood vessel which effectively bypasses that, and you take blood from your bowels and your digested food straight to the brain without it being detoxed, and you can have seizure-like activity in a youngster. So because it's congenital, because something you're born with, you'd expect to pick it up soon. If you were born with this problem, you wouldn't expect to pick it up for the first time when they're 10. So in a very young dog, a few months old, could be epilepsy, but it could be problems outside of the computer again. Typically think about this liver issue. If there's a pattern to the seizures, also look for that pattern. I've spoken, my dog Ellie used to have it curiously standing at one particular spot in the garden, curiously over a cable, an electrical cable, well, not a high voltage cable, but it seemed to be there that she'd have the turns, and it didn't make any sense to me. And I chatted to a neurology friend of mine, and he said, yes, he has seen patterns like that too. One dog, for example, every time he heard the dustbin lorries arriving to take away the rubbish on a Thursday morning, the dog would have a seizure. Why it's triggered like that, it doesn't make sense, and nobody knows. So there can be patterns, and as the vet, we're going to ask you, is there a pattern associated with it? So again, we're thinking about when we see it, like how old is the dog? If you've got a very old dog and they've got other symptoms like appetite disturbances or water intake disturbances, again, you might think, are you in kidney failure? Are you in liver failure? Do you have diabetes? Is that what's affecting the brain? Is it a problem perhaps outside of the brain? So we go back again to the very beginning, and we're trying to distinguish, is it in the brain or is it not the brain? So what your vet will suggest we do, and the Rolls-Royce investigation of these cases would be have a brain scan, have some blood tests, and have effectively a lumbar puncture to check the fluid around the brain. So what do we get from all of this? If we do some blood tests, we're doing just a general screen on how is your body, how healthy are you, what are your sugar levels doing, what are your kidneys doing, what are your liver doing. If all of that is absolutely fine, then the probability of you having something in the body rather than in the brain is unlikely. Never say never in the medical world, but if the blood tests come back normal, probably the problem is in the brain. If it's in the brain, then we would split the two problems that you might have in the brain into a structural problem or a functional problem. A structural problem means there's a problem excuse me, with the structure of the brain. What do I mean by that? Bluntly put, if the structure of the brain is disrupted, probably the most common cause is going to be a tumor process. So you put a great big blob of blue tack in the middle of your computer's keyboard, motherboard, you're going to get a problem. So we do the brain scan to look for, does the brain look normal, yes or no? If it looks abnormal, then we can say, all right, well, there's scarring in there, there's been a trauma, there's been a big stroke perhaps, or there's a tumor, there's something damaged within the brain, and that will explain why we have the epilepsy. If the brain looks absolutely fine, then in a perfect world, we'd want to do a lumbar puncture and just make sure that there's not inflammation in the brain, because inflammation won't make it look abnormal, but it'll certainly make it function abnormally. So on a lumbar puncture, you would take some fluid from the fluid that surrounds the brain, have it analyzed, and if that all comes back normal, so the brain looks normal, the fluid looks normal, the blood tests are all normal, then we have what's called a functional brain disease, which means the computer, the brain, it looks normal. I open up the computer, it's not working. It all looks fine. No, there's nothing nesting in there. You haven't messed anything in there. Nothing's blown up. Nothing's smoking. It's just not working as it should. That's a functional brain problem. And that is how you reach the diagnosis of epilepsy. In human beings, I think they're a little bit more advanced in terms of the testing, and their patients, us, are slightly different to veterinary patients. So they can actually do some very specific tests that say, is this epilepsy, yes or no, in many cases. In the veterinary world, it's usually an ECG they do in people. In the veterinary world, we just don't, it just doesn't work. It doesn't seem to be a correlation between the ECG that you'd get from the patient and a confirmed diagnosis of epilepsy. So we have a bit of a clunky way of diagnosing it. We do the tests, so we prove that it's nothing outside of the body, we prove it's nothing structurally in the brain, and there's no inflammation going in the brain. And by a process of elimination, we say, well, if it's none of those things, then if we're going to attach a stamp to you, we're going to say, right, the stamp on you is you are epileptic, meaning the brain is short-circuiting, it's getting stuck buffering, it's shutting down, it's freezing up, whatever analogy you want to use to the computer. There's something going wrong in the wiring of the brain from time to time for no sensible reason, and it's something which, when you reboot your computer, it all comes up and works again. Your brain, when it reboots, you're fine again. So epilepsy is this, we don't know why you're having this short circuit in your brain process, and we know what it's not. So as soon as we have ruled out it's not all those things, that's the diagnosis you're left with. So what to do about it? We don't really get the brain anywhere near as much as we would like to do. So we often know what drugs and medications do to the brain. So for example, if I give you a general anesthetic, I know you'll fall asleep. So we know cause and effect with the drugs, but often explaining exactly how they do that, exactly what is going on there, we're a bit more wishy-washy. So your anti-seizure medications are very much the same. So we have anti-seizure medications, a variety of them to choose from, or anticonvulsant medications, which we know what they do. We know if we give you this medicine, it'll most likely do that, and it's very predictable. We know it works oftentimes on GABA receptors in the brain, and it releases the chloride from the chloride channels. But exactly how this big mushy thing we call our brain, exactly how it works, we don't really know. And that's good and bad. It's bad because we don't know. It's good because even if you had a tumor, for example, and it's not operable, which is generally not in human beings, and as an aside, although brain cancers are not uncommon in human beings, in dogs they're much, much less common. So if your dog's suddenly seizuring, then don't jump to brain cancer as the first thing. It's possible, but it's not at the top of the list. Probably epilepsy, if you have a seizuring dog, is at the top of the list, and we just go through the process of excluding all the other things. Having said that too, you don't have to do this full workup every time. I think in all the years that I've had seizuring dogs where I'm satisfied that it's seizuring, not syncope, when I have done the blood tests, I don't think I've ever got anything useful back from it. I don't think I've ever got a result that's gone, you're not epileptic, or you don't have it's not a primary brain problem, it is metabolic, it's in the rest of the body, and ta-da, we treat that and you're fixed. I don't think I've ever had a case like that, but we look every time because that's the protocol, and the one case I decide not to do that, you can rest assured will be the case where I should have. So we always look, but almost always if you have a seizuring dog, almost always it's going to be in the brain, unless it's a very old, worn-out dog, yes, where liver and kidneys can play a role. But as a broad rule, do the bloods, but probably it's just going to be a rule out, and then you're left with the brain. Yes, ideally you'd want the MRI and the CSF tap for sure, but it's expensive. You're looking at a few thousand pounds or dollars to investigate it. And if you're not minded to do major surgery on these guys, then you're still really just down to anticonvulsive treatments, because they treat the brain by just stabilizing the neurons in the brain, making them less inclined to short fire, less inclined to go off, irrespective of what it is that's freaked them out in the first place, whether it's, like I say, structural brain disease like a tumor, or whether it's true epilepsy. The CSF, you could argue, yes, if you've got something like meningitis or encephalitis, and it can be autoimmune, where your immune system's attacking itself, yes, then it would be a very, very different treatment. But those cases are far and few between. So for most of us, the prospect of spending a few £1,000s on an MRI or a CT scan, which is unlikely to yield a big surprise diagnosis, which will massively change our management of the case, it's unlikely that's going to happen. So I think if you've won the lottery and you've got the money, please do it. Absolutely, it's the right thing to do. But if your budget doesn't stretch to it, you're not a failure as a human being. You haven't failed your dog. It's not the end of the world. We can just we can play the numbers, and we say, well, 99% of these cases are probably going to be epilepsy without any other crazy stuff going on. So you're back down to choosing your medications, and it's going to come down to anti-seizure or anticonvulsant medications, even if you had the brain tumor, even if you had epilepsy, and even if sometimes you just don't know. Again, you still just try the anticonvulsant because it doesn't discriminate between the different causes. So what can we choose from? Well, put it another way, start at the beginning. Why would we start treating you versus not treating you? And there's an old maxim that says one seizure is no seizure. So if your dog has had a seizure for the first time ever, they're somewhere between 2 years and 10 years, 12 years old, and they've never done it before, of course it freaks you out. Of course, have a discussion with your vet. Of course, have them checked out. But we're generally not going to necessarily launch a huge investigation, and certainly not initiate treatment on the basis of one seizure, because the old maxim is one seizure is no seizure. So we're going to record it, keep the data, look at it, maybe run some bloods there and then just to rule out that it's not something outside of the body. But probably I would normally say to people then, sit tight. So we're not going to start treatment just because you tick the box of having had an episode. So where we do want to start treatment is if you're clustering. So if you go into a seizure and then come out of it and then go into it and come out of it, and this will be like within the same 24, 48 hour period. So the clustering is literally that, dipping in, dipping out, dipping in, dipping out, but never really coming out completely. Then absolutely you want to treat. If you're going to status, so you go into this jerking convulsive thing for more than 2 or 3 minutes and you don't come out of it, that jerking and that muscle spasm and that just tightness and nothing's working as it should can interfere with your respiratory muscles. And if it interferes with your respiratory muscles, you're not getting enough oxygen to the brain and you can have brain damage. So the second criteria is if the episode's lasting more than about 2 or 3 minutes, then definitely you want to you'd want to investigate and start some treatment. Thirdly is how often are they happening? So ignore the clustering. How often are they happening? So for example, if you have 1 seizure a year, you're unlikely to want to start treatment. If you're having 2 a year, probably you wouldn't want to start treatment. So where's the cutoff point? And I think in crude terms, if you're having more than 1 a month, then really you should think about investigating as far as you decide to investigate and initiating treatment. So, and the fourth category is if you as the pet owner or me as the pet owner are extremely distressed by them and you're not necessarily ticking all the other boxes, we can start you on anti-seizure medication. So there are some crude criteria for where we start, but it's pretty much a discussion between you and your vet to decide what's appropriate in your context. So what are the choices? You get various choices. So the traditional mainstay in the veterinary world is a drug called phenobarbital. It's a wonderful drug. It's been around a long time. We know what it does. It's cheap as chips. But there's pros and cons to each drug. So those are all the pros. The cons are that they do require blood tests, monitoring blood tests, because you could line up 10 dogs or 10 people, give them the same drug, but the actual amount that ends up in their blood supply will be different between each individual. So we need to put you on the medication, and then we need to use blood tests to tell us whether we've got adequate levels in your blood supply. Once we know that we've got adequate levels, meaning we don't want to be overdoing it or underdoing it, then what is our expectation? And this is an extremely important point. When we treat someone with epilepsy, we're not going to fix you, we're not curing you, you're not mending you. You are going to be, if that medication works, what is the criteria for saying that medication works for you? And you basically want to have an 80% reduction in your problem. So an 80% reduction in the frequency of your seizures and an 80% reduction in the severity of your seizures. If you're achieving that, pretty much that's a success. It's unlikely that you will never seizure again. And so once we achieve that state and we've confirmed on the blood tests that we're not overdoing it or underdoing it, because overdoing it is bad for your liver, once we know that, then we'd probably just keep you on that medication long term. Sometimes we do find a curious case where we do the blood tests which say that you're under-medicating that individual, so you're under where you should be in terms of your blood level, but you have no seizures. In that case, treat the dog, not the patient. I beg your pardon, treat the dog, not the blood test. If there's a discrepancy between how you're going to make up your mind, it's what's happening in that individual dog, because that's what we're trying to achieve. So I've seen some dogs who will maintain on low levels of the drug which are not in the therapeutic range. So the blood test says your level's not high enough, you should increase the dose, but the dog's not seizuring, then I'm going to leave it there. And I know that if he does in the future, I've got a bit of leeway to adjust that. When you're on phenobarbital, it will have significant side effects. Certainly in the beginning, you get a dog who's very woozy and very stoned on it to begin with. So much so that a lot of people say, I don't want my dog on this drug, he's a zombie, I don't want him like this forever. Grit your teeth, get through it. We usually start at a dosage rate of about 3 to 5 milligrams per kilo twice a day, and they will look pretty hammered on it, to the point where sometimes they struggle to walk. I mean, they look like they've been on a stag do for a long weekend in Prague. So don't lose faith. Certainly discuss it with your vet, but don't lose faith. It takes a week or two, and the brain and the body gets used to it, and then they'll stabilize that. The instinct is cut the dose, cut the dose, cut the dose. Well, if you cut the dose at that point, and you've got the indications to treat this dog, like long seizures or repeating seizures or cluster seizures, do not pull back. You've got to control these guys. Once they've settled on that dose, you'll see after a week or two they'll get less unsteady, they look less like a drunkard. Then the next side effects you're going to see are appetite and thirst. They'll generally drink a lot and eat a lot. And if they're drinking a lot, they're going to pee a lot too. So be mindful that you take them out first thing and last thing. Those symptoms are 50-50, sometimes temporary, sometimes permanent, and unfortunately they're just a necessary evil. They go with the drug. If we don't like the drug for any of those reasons I've discussed, there are alternatives. We can try potassium bromide, which you think of it just as like a kind of salt, like table salt is sodium chloride. This is potassium bromide. That pros and cons of that, it's cheap, which works very well. Cons are it's a very slow loading drug. It takes several weeks to actually get into your body, get into the blood levels that you want. So it's not necessarily a good choice when you're in the crisis situation at 2 o'clock in the morning when the dog's seizuring and won't come out of it. I think it's not a great choice. Again, it would only be about 80% relief for each individual. So if you are on either one, the potassium bromide or the phenobarbital, and you feel you're just not getting the result you want, and you've done the blood test for both drugs and confirmed that you are in the therapeutic range, and specifically in the top half or the top third of the therapeutic range, so near the top without being over the top, and it's not working with either one of those, you can piggyback them. You can use both at the same time. And then that will sometimes give us better control. An alternative to those two is a drug called Pexion. Pros and cons again. It's a good drug. It's much more expensive than the others, so you pay more for the drug, but you don't rely on the blood testing for the blood levels. You just adjust according to effect. So that's an alternative. And really, it can have much the same side effects. In my experience, less severe certainly. So Pexion has less severe side effects than the other ones, but that doesn't make it better or cleverer or stronger. It's just whatever suits your budget and whatever works for your dog. So I think the take-home messages is if your dog is epileptic, don't despair. The vast majority of these guys, we will control them. We will restore a good quality of life for the vast majority. And if it's just not working, don't get frustrated. Just grit your teeth, get through it, go through the methodical steps of testing. Have I got your blood levels correct? Am I in the top end of the range? If I am and you're still not working, either switch out to another drug. Don't stop one abruptly and start the other necessarily, but bring in another one, piggyback them, and just fiddle around with it. Like I say, the vast majority will stabilize, even though your first instinct might be that this is just so awful and so terrible in the first few weeks that you think you're contemplating euthanasia. I would encourage you to not go there. Just find a sympathetic ear and a sort of a knowledgeable vet, and just let them guide you through the process. Like I say, I had an epileptic dog myself. Very, very disappointing. She was the classic dog. She started having her first seizures at about 3 years old. She had once, initially she would have one every 6 months or so. They were very short duration, 2 minutes, and she was out of it and fully recovered within a few minutes. So I actually didn't even investigate her, which I don't know if that makes me a bad dog owner. But they were so infrequent and so almost inconsequential, apart from the awfulness of it at the time. There was no residual effect, didn't affect her in any way. But over time, when she was about 6 or 7, they did become more frequent, and I did start medicating, and I was one of the unlucky ones where she didn't just stabilize nicely on my first choice medication. She ended up being on combinations of medication, and sadly with mine is one of the exceptions. She did just get worse to the extent where I've had her on all the drugs and it just wasn't enough to get her out of extended status, and everything failed, and sadly that was the end of that. But I was extremely unlucky, and almost never have I gone through quite such a awful deterioration and hopelessness with other dogs other than my own. So I think there's cause to be optimistic that you can control and help these guys and get on and have a long, happy life. So I hope that was of some benefit to everybody. Thank you for sending the request in to discuss epilepsy, and I wish you all a very good night. Remember, Nico the Vet. Subscribe if you like. Otherwise, just send me your requests for topics you'd like me to discuss. Or if there's something I did discuss and you want more detail, I can revisit it. Thank you all very much. Good night.